Good afternoon, and thank you for joining today's Focus on Eye Health series, advancing eye health through data communication, through data, community, and policy, including a spotlight on our 2025 Rising Visionary Award honoree. I'm Jeff Todd. I'm President and CEO at Prevent Blindness, and I'll be your moderator for this forum. For those who would be assisted by an audio description, I'm a white male in my mid 50s with dark thinning hair. I'm wearing glasses and a multicolored sweatshirt and sitting before a light background in my home in beautiful Chicago. Today, we'll learn how integrating social determinants of health into vision and eye health research, programs, and policy can reduce disparities and expand access to care. Our speakers will highlight the role of data, community engagement, and cross-sector partnerships in identifying and addressing barriers to eye health in underserved populations. Dr. Patrice Hicks, our 2025 Prevent Blindness Rising Visionary Award recipient, will share insights from her work applying social determinants of health research to inform policy and clinical practice. She'll be followed by Dr. Karen Allison, who will explore how public health data drives effective strategies to reach those most at risk. And then finally, Philip Goglas will close out our session with a look at how federal policy and funding priorities shape our approaches to public health, including national vision and eye health initiatives. He will discuss the vital role of advocacy in influencing those decisions. And now I'd like to thank our sponsors of the Focus on Eye Health webinar series. Our platinum sponsors are the Alliance for Aging Research and Pharma. Our gold sponsors are Amgen, Bio, the Bright Focus Foundation, the Collaborative Community on Ophthalmic Innovation, and Genentech. And now I'm excited to kick off this terrific webinar, starting off with Dr. Patrice Hicks, an assistant professor at the University of Michigan Department of Ophthalmology and Visual Sciences. Dr. Hicks was selected as the recipient of the Prevent Blindness Rising Visionary Award, which recognizes a student or resident in optometry, ophthalmology, primary health care, nursing, or other health profession who has the best overall application and essay in response to this year's essay request. Identify an opportunity where the need for a collaborative, multidisciplinary approach in the development of vision and eye health research, programs, or policy can address eye health challenges. Dr. Hicks' award submission emphasized leveraging social determinants of health research to identify and address key factors affecting vision and eye health disparities, such as income, education, neighborhood resources, and healthcare access. We're going to hear a lot more of that in just a second. So we're excited to present Dr. Hicks the 2025 Prevent Blindness Rising Visionary Award. Please welcome Dr. Patrice Hicks.
Thank you, Jeff, for the kind introduction. Hello, everyone. I'm excited to be with you all this afternoon to share our work with you all. I'm a woman in my 30s with brown hair pulled back into a ponytail and brown eyes. I'm wearing a black top with a navy jacket, and I am sitting in front of a University of Michigan medical campus background. I want to thank Prevent Blindness for the Rising Visionary Award and the opportunity to share our research with you today. My presentation is entitled Seeing the Divide, How Neighborhood Socioeconomic Status Shapes Vision Health and Why National Data Matters, which will discuss two recent studies on national measures of visual difficulty and blindness in neighborhood measures. The funding for this research did not impact the design and conduct of the study, collection, management, analysis, or interpretation of the data. So my previous research has focused on eye health equity in the space of eye care and vision health. For orientation, health equity is when everyone can obtain optimal health regardless of race, ethnicity, sex, income level, or other social factors that create barriers to health. These are two graphics that are used to explain health equity. The top one comes from the Robert Wood Johnson Foundation and highlights that not everyone needs the same kind of support. The bottom apple tree illustration has been used to illustrate the distinction between equality and equity. Social determinants of health are estimated to account for 80 to 90% of not modifiable health factors, while the medical care a patient receives only accounts for about 10 to 20%. While eye care providers strive to provide excellent care for patients, unfortunately, what is known and understood about social terms of health and how they impact both patients' lives and health, solely providing exceptional personalized care will not achieve equity in eye health and vision care. Thus, it is imperative to expand the eye care team and breadth of research within eye care and vision. Social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect health functioning and quality of life outcomes and risks. This graphic comes from Healthy People 2030, in which 5 critical domains of social determinants of health have been identified, and they include healthcare access and quality, education access and quality, social and community context, economic stability, and neighborhood and built environment. Social determinants of health also contribute to health disparities, including eye and vision health disparities. Health disparities are a health difference based on one or more health outcomes that adversely affects defined disadvantaged populations. These populations include racial and ethnic minority groups, underserved rural populations, persons with less privilege from any or ethnic or ethnic group, persons with low incomes, and sexual and gender minority groups. Research in this area examines adverse health outcomes for these populations and what my research has focused on. The studies I will be sharing with you today focus on the neighborhood and built environment domain of the social determinants of health. My previous research in this space has examined neighborhood measures of inequality, including redlining, income inequality, persistent poverty, and neighborhood segregation, and has found that when these measures are worse, they are associated with higher prevalence of residents reporting visual difficulty and blindness. My first study I will be sharing with you today utilizes a large national data set and is entitled Margins of Sight, Neighborhood Disadvantage at the Census Tract Level and the Association with Visual Difficulty and Blindness in the United States. Visual impairment can impact daily activities and limit participation in work, education, and community life, especially for Americans living in communities with fewer economic and social resources, who experience higher rates of visual impairment and lower eye care utilization. By collecting data on neighborhood deprivation, we can identify individuals and communities at greater risk for visual impairment and help address these disparities. The purpose of this specific study was to assess if there is a greater estimated percentage of people who are blind or who have difficulty seeing even when wearing glasses in census tracts with greater neighborhood deprivation as compared to census tracts with less neighborhood disadvantage. The study used 2 data sources. The first one is the National Neighborhood Data Archive, also known as NANDA, and the American Community Survey. The exposure variable was neighborhood socioeconomic disadvantage, which was sourced from NANDA with 5-year data from 2018 to 2022 at the census tract level. This measure is also available at zip code level to use when eye and vision outcomes may not be available at this more granular census tract level. Neighborhood disadvantage was measured by economic drivers of disadvantage, including proportion of people living in poverty, proportion of families receiving public assistance income, and proportion of people with low family incomes, which was identified as less than $40,000 per year. The measure is an aggregate measure ranging from 0 to 1, where increasing values means that there's more neighborhood disadvantage. The outcome variable was derived from the visual difficulty and blindness data utilizing the 2018 and 2022 American Community Survey. So this is the same years that was used for the deprivation measure as well. The ACS surveys the civilian non-institutionalized population who self-report visual difficulty and blindness by responding to the query, "Are you blind or do you have serious difficulty seeing even when wearing glasses?" at the census tract level. We conducted data cleaning and summarization, and descriptive statistics were performed, and univariate associations between neighborhood disadvantage and visual difficulty and blindness were analyzed using Pearson's chi-squared test. We then used logistic regression models to assess the relationship between census tract disadvantage and visual difficulty and blindness, with results reported as odds ratios, 95% confidence intervals, and two-sided p-values, where p less than 0.05 was considered statistically significant. Our multivariable models were adjusted for median age, the percent of female residents in the census tract, the log transform percentage of population that identified as a racial or ethnic minority group, log transformation of population size, and the state that the census tract was in. Rates of visual difficulty and blindness were determined as events per population within each tract. In total, the analysis included a little over 83,000 census tracts in the United States, and on average, a census tract was about 40 years old. 40% of residents identified as a person of color, and 50% of residents identified as female. The average neighborhood disadvantage score was 0.18. We also see that all the neighborhood demographics were positively associated with visual difficulty and blindness, except for population size. So in our logistic regression model, assessing the association between disadvantage score and visual difficulty and blindness, we see that in the multivariable model, a 0.1 unit increase or worsening in disadvantage score was associated with a 33.5% increase odds of visual difficulty and blindness, and that was after accounting for census tract demographics. We can see in this table, table 3, that we observed similar results in the logistic regression model, which excluded census tracts that we considered unreliable. Specifically, these were census tracts that had a coefficient of variance over 40% for visual difficulty and blindness. In this model, a 0.1 unit increase in disadvantage score was associated with a 22.5 increased odds of visual difficulty and blindness. This study found that visual difficulty and blindness is associated with neighborhood disadvantage at the census tract level, which is consistent with other vision research, examining block level area deprivation index and various poor vision health outcomes. The NANDA neighborhood disadvantage measure helps identify communities at higher risk of visual difficulty and blindness, allowing for targeted vision screenings and interventions by clinicians, researchers, and policymakers. Census tract level neighborhood disadvantage measures can be used by researchers as an alternative when census block group or zip code data is not available, and this helps to facilitate the integration of neighborhood level data from various sources and supports efforts to improve vision outcomes through early detection and treatment. The next study I will be presenting is called Looking Past Disadvantage, the Role of Neighborhood Affluence in Vision Difficulty and Blindness across the United States. And this study will directly build upon the previous study. So affluence provides access to health promoting resources like transportation, insurance, and nutritious food, and is often a strong predictor of self-reported health. While studies show that affluence can protect against poor health outcomes such as certain cancers, stroke, and adverse birth outcomes, its relationship to vision health outcomes has been less frequently explored. Higher income, employment, and education have each been linked to better vision outcomes, including lower rates of vision loss. Studying neighborhood affluence in relation to visual difficulty and blindness fills a gap in the literature, which has mostly focused on deprivation rather than the positive effects of affluence. The purpose of this study is to assess if there is a greater estimated percentage of people who are blind or have serious difficulty seeing even when wearing glasses and less affluential census tracts as compared to more affluential census tracts. So similar to the previous study, this study also utilized data from NANDA and the American Community Survey. The affluence variable came from NANDA, which is a metric that includes a concentration of people who are highly educated, so adults with college education, hold professional or managerial occupations, and have family incomes in the higher range of the national income distribution, which was assessed at greater than $125,000 per year. Again, this measure is also an aggregate measure, so it ranges from 0 to 1, where increasing values means that the census tract is more affluent. We conducted the same statistical analyses as the previous study, but the exposure variable for this study was affluence. We also conducted the same models and adjusted for the same neighborhood level factors. We utilized the same data set as the previous study, except now we are assessing affluence. We can see here that affluence is inversely associated with visual difficulty and blindness, meaning as neighborhoods become more affluent, there is less visual difficulty and blindness reported. Logistic regression models assessing the association between affluence score and visual difficulty and blindness are presented in Table 2. In the multivariable model, we can see that a zero point 0.1 unit increase or more increase in the affluence score or more affluence was associated with an almost 19% decreased odds of visual difficulty and blindness after adjusting for census tract demographic factors. Again, we see similar results when we conducted our sensitivity analysis, which excluded census tracts with unreliable census tracts of that coefficient of variance of over 40% for the visual difficulty and blindness measure. In this model, a zero point 0.1 unit increase in affluence score was associated with a 13% decreased odds of visual difficulty and blindness. This study is the first to examine the association between neighborhood affluence and visual difficulty and blindness at the census tract level. Findings, we found that higher neighborhood affluence was linked to lower rates of visual difficulty and blindness. These results highlight the need for future research into how neighborhood affluence uniquely influences eye and vision health outcomes. I also think that this work has policy implications. First, targeted vision health interventions. Policymakers and public health officials can use census tract level measures of neighborhood disadvantage, like NANDA, to more effectively target vision screening, education, and treatment resources to communities most at risk for visual difficulty and blindness. In addition, integrating neighborhood affluence and disadvantage indicators into healthcare planning allows for more precise and equitable allocation of funding, services, and personnel to prevent and treat visual difficulty and blindness in underserved areas. In addition, for research and public health surveillance, adopting census tract level geographic measures promotes consistent data collection analysis across studies and regions, supporting evidence-based policy decisions and more effective public health strategies to improve vision outcomes. So why should this data continue to be collected? Ongoing collection of visual difficulty and blindness and neighborhood affluence and disadvantage data, as well as some of the other measures I previously mentioned, allows clinicians and public health researchers to monitor trends, identify high-risk communities, and track the impact of interventions over time. Including these variables in clinical and epidemiological data sets supports the development and evaluation of effective evidence-based programs tailored to social and geographic factors affecting vision health. Consistent data collection uncovers and addresses disparities in vision outcomes, guiding resource allocation and policy decisions to promote equitable access to vision care across populations. Without this data, at-risk communities may be overlooked, resulting in missed opportunities for early intervention and prevention. Without accurate data, healthcare planning and vision screening may not reach the areas of greatest need, leading to efficient or equitable resource allocation and ongoing disparities in vision health outcomes. Additionally, insufficient data on social determinants of health limits research and policy development, hindering the creation and evaluation of evidence-based strategies to reduce vision health disparities. I'd like to take this time to thank all my collaborators on this work at the University of Michigan, Wayne State University, Eastern Michigan University, the University of Utah, The Ohio State University, and the University of Chicago. I want to thank you all for your time this afternoon. I will take any questions during the Q&A portion of this session, but also wanted to provide my email and socials in case you have any other follow-up questions after today's presentations. I will now hand it off to Dr. Karen Allison for her presentation.
Thank you, Patrice. That was very insightful. Good afternoon, everyone. My name is Karen Allison. I'm a Black female with brown hair, and I'm at my desk at the University of Rochester in a brown top, and I'm excited to present my research to you today. So the topic of my research, impact of social determinants of health on ocular diseases in Western New York, a comparative analysis of Monroe and Erie County. I currently work at the University of Rochester, which is in Monroe County. Next slide. I have no conflicts. Next slide. So social determinants of health, as Dr. Hicks said, has many features that can affect someone's health. It's not just the health of the person, but the many factors that contribute to someone's living situation that can affect their health. And in fact, healthcare is only about 20% of the factors that affect someone's health. It has to do with their educational access and quality, the neighborhood and built environment, social and community context, economic stability. And this data was obtained from Healthy People 2030 that shows the five main factors that affect people's health. But one of the factors that's not included in this, of course, is food insecurity. So the three diseases that we're going to highlight today is glaucoma, diabetic retinopathy, and age-related macular degeneration. So the leading cause of blindness globally and associated risk factors is cataract. Age-related cataract is the number one cause of blindness, and there's some, as one gets older, there's increased risk of getting cataract, but there are also many factors, environmental factors, that can contribute to cataract, such as UV light exposure, diabetes, drug ingestion, smoking, alcohol use, trauma, and multiple others. And the second cause of blindness and the number one cause of irreversible blindness is diabetes. This has modifiable risk factors as well as unmodifiable risk factors. The unmodifiable risk factors may include family history of glaucoma, increased intraocular pressure, and age. The modifier risk factors may include diabetes, trauma, steroid use, and some other factors. As far as age-related macular degeneration, this also occurs more highly in patients that are older. And this also has modifiable risk factors, such as smoking, dietary intake, and decreased intake of antioxidants. And of course, with all these other diseases, it increased frequency with aging, and that's an unmodifiable risk factor. Now, the fifth cause of blindness and the number one cause of blindness in the working class adult is uncontrolled diabetes and diabetic retinopathy. And this is the risk factors may include uncontrolled diabetes, increased hemoglobin A1C, hypertension, and just any obesity, poor dietary intake. These are all risk factors for diabetic retinopathy. Next slide, please. So what we did in at University of Rochester, we decided to look at Erie and Monroe County to see what the differences was, if there was any. Erie County and Monroe County, they're both in upstate Western New York. Erie County has a population of about 1 million, and Monroe County has a population of about 900,000. And the reach for each county is over 1 million. The biggest city in Erie County is Buffalo, and in Monroe County is Rochester. It has very diverse community, but as we'll speak later about how the city is made up. So we looked at publicly available data from the VHSS, American Community Survey, the county health rankings for 2019, the ADI data from the Neighborhood Atlas, and we strategized and compared the data from Rochester, Monroe County, and Erie County, and Buffalo area to see what the findings were. And for each continuous outcome variable two sample t-tests were used to compare the mean values for the two counties, and for each categorical variable, person's chi-square test was used to compare the distribution between the two counties, and the significance level was at 0.05 for each analysis. Next slide, please. So the first thing we looked at was blindness in Monroe County area. And as I said, Monroe County covers about over 1 million people. The center of the healthcare system in Monroe County is the University of Rochester, which has the reach of about, not only does it cover Erie County, it goes all the way as far as to Syracuse and then extend to Cleveland. So and it's the #1 trauma center in this upstate New York area. And one of the things that we found, and we compared it to Kings County, which is in Brooklyn, and which has a much larger population. And what we found was the rate of blindness in female was much higher than male at every endpoint. And the rate of blindness in Monroe County was higher than the other counties all combined. Next slide, please. Then the next thing we looked at was ocular prevalence of ocular disease prevalence in Monroe and Erie County. And we also looked at New York State and the USA in general in 2019. What we found out was that in general, glaucoma was the highest disease prevalence in all the different areas, Monroe, Erie County, New York State, and US overall. And followed by age-related macular degeneration, and they followed by diabetic retinopathy, which was even in all counties, as the rate of diabetes is improving, and even more so now with some of the newer medications that we have. Next slide, please. Then we looked at the age range of patients with macular degeneration, diabetic retinopathy, and glaucoma. And as you'd expect, the macular degeneration is highest in patients that are over 65 and with an increased incidence at over 80. And what we found was that in Erie County, we have a higher rate of macular degeneration versus Monroe County. And with diabetic retinopathy, it was even in both counties, meaning Erie County, Monroe County was about the same, with the highest prevalence around 40 to 80, 85, and after that it decreases somewhat. And with glaucoma, another disease of aging, as some people get over 40, the incidence of glaucoma continues to increase. And what we found was that at about between 60 and 85 was a little bit higher in Monroe County, in Erie County versus Monroe County, but over 85 was about even. The population dynamics in both areas, diversity, is about the same, with the proportion of Blacks, Hispanic, whites. There's a higher population of Native American in the Erie County, Buffalo area than, say, in the Rochester, Monroe County area. Next slide, please. So the other thing that we looked at was race. We looked at how these diseases were extrapolated over race. We looked at Asians, Blacks, Hispanic, Native Americans, white, non-Hispanic, and other. And the other would be people that may not have put their race down or were of mixed race. And what we found was that with macular degeneration, the highest rate was with white, non-Hispanic. And it was higher, as noted before, in the Erie County area versus Monroe County. And there was also a high spike in the Asian, and Asian not only meant it also meant Southeast Asians. So that there's a high incidence of macular degeneration in that group. When we look at diabetic retinopathy, it was about the same across the different races, except for Native Americans, which had a very, very high spike of diabetic retinopathy in the Erie County area. And as I noted before, Erie County had a higher number of Native Americans than the Rochester area. The next thing we looked at at about in the glaucoma area we had higher rates in the Black, non-Hispanic, and the Asian um, air in the group, with a higher rate of glaucoma in the Erie County versus the Monroe County area. Next slide. So when we look also at the uninsured rate, New York is one of those states that expanded Medicaid. So the rate of uninsured was about the same in all counties. It was much lower than in the US in general. And the number of primary care physician ratio to population was lowest in Monroe County with about 900 to 1, while the US average was about 1,300 to 1. And Erie County was around the same as New York State. And other primary care providers, such as nurse practitioners, physician assistants, was also lower in Monroe County versus the US, which was about 500 to 1 versus 1,000 to 1 in the US. Next slide, please. Some of the social factors, adult smoking was about same in both counties. Obesity rate was about the same. Food environmental index was about 7.9, and this was lower, about the same in lower in Monroe County than in Erie County versus New York State. The lower the number, the better the index versus the high number. The high it's an index of from 0 to 10. The percentage of adults reported no physical activity was about the same, and a percent of population with access to exercise was also about the same, with within Monroe County and Erie County, which was higher than, say, in US in general. And the segregation between blacks and white was about the same, which in New York State and Erie County, a lot lower in Monroe County. And the segregation index means that black and white index of substantial was higher, with greater residential segregation between white versus more segregation. Next slide. Next slide. And this map is interesting to show how the areas that were with the area deprivation index, the darker the area, show that the higher the rate of the increased index of increased ADI, meaning that there is more poverty or loss of resources in these areas. And this is the Buffalo area. In Buffalo, the zip codes of 14207 has the highest poverty. And this is the Rochester area where they also have a very high poverty area. And this is where the University of Rochester is located. So the poorest area in Rochester is area code 14605, and it's also a crisis center, which is very close to where the university is. So the higher the poverty and the lower resources area, the higher the darker the area. And the more affluent areas, the lighter the areas, which is these lighter areas. And there is an area in Buffalo called Millionaire Row. And this area is right here. Next slide, please. So, although Erie County exhibit worse outcomes in macular degeneration glaucoma prevalent compared to Monroe County, both counties are still affected by disparities in cares and outcome as other areas around the U.S. So, some of the things that we can do, of course, is education, increase food stability, increase in education access, increase in job security, and increasing not only access to care, but also quality of care. Next slide, and living conditions of the underprivileged communities. Next slide, please. So advocacy is important, and with looking at the area that you're studying and presenting the evidence to federal and state leaders and local leaders will help to allow them to see exactly what some of the problems are and will help to reshape access to care and redefining the eligibility of certain of insurances such as Medicaid, with the fact that extending opening Medicaid eligibility, more people will have access to care and coverage, increasing the coverage structure, identify individuals at risk by creating screening tools for not only for the ophthalmologists, but also for primary care doctors where the patients are most reliable to go, and giving them robust mental health consideration in these areas of multiple risk, and highlighting disability and health inequity so that we can provide better not only eye care but disability care, because it all involved in creating a healthier person, and of course optimizing mobile clinic and telehealth and increasing a diverse workforce. And last slide. So it is critical to increase the general population trust in healthcare. Usage of public education and screening programs is helpful, but it's not the only answer. Cultural humility and training and increasing diversity in the workforce is also crucial. And next slide. And next slide. So in conclusion, we have to ameliorate these health inequities. It's important to focus on social determinants of health and underlying systemic problems that increase the burden on minority populations. And it's important to look at where the issues are, reaching out to the communities that are at risk, finding out what their needs are, and helping and working with them in order to make changes. Because unless they are involved in the change and are major stakeholders in making some of these changes to their environment, nothing is going to work. By addressing the underlying problem, lack of resources, systemic racism, segregation, redlining, then some of these issues can be treated, improved for healthier outcomes, including ocular health, and it will take everyone, including the patient and the people involved in the communities, to do that. So next slide, last slide. And so all advocacy at its core is an exercise in empathy, but we have to make sure that we are embedded in the communities so that the patients know that we care and we're part of the change. Thank you, and I look forward to any questions. And we will go to Philip Goglas, who will talk some more about our advocacy and federal policy. Thank you.
Thank you, Dr. Allison. And I hope everybody can see my screen. It's a pleasure to be with you today. I am a brown man in my 30s with short black hair, wearing a white collared shirt with a blue and greenish checkered tie in front of a blue Prevent Blindness background. As was mentioned in the introduction, I work here in Washington, D.C. as Prevent Blindness's D.C. representative. So here today to talk about the wonderful world of advocacy. So first, why does advocacy matter? Advocacy is critically important because it helps to elevate the voice of constituencies. It helps to build lasting relationships with Congress. Advocates are considered informed and expert resources for decision makers before they vote on a specific policy, introduce a specific policy, or take a position on a specific policy. And an advocate educates Congress on important items related to public health, including vision health. And when you advocate, it's directly influencing and engaging through the appropriations process, which we'll talk a little more about here as well. So first, how advocacy creates champions, shapes policy, and secures funding. Our advocates, by providing local information, they help their members understand why supporting a bill is critically important, or a funding recommendation, how that will provide a local benefit. And the more congressional champions we have, the more bill co-sponsors we have, the more we're likely to see that bill passed and signed into law, which is critically important. We also advocate in a bipartisan approach. So everything that we do is not a Republican bill, it's not a Democrat bill. We work very well with both sides of the aisle. And it's critically important that we continue to do that, because when we build this bipartisan approach, we continue to engage both sides and we don't get caught up in the politics of the day, but we're really able to focus in on that policy solution that gets both Republicans and Democrats to the table to support that, which again increases the likelihood for a bill to get passed. If you have a piece of legislation that is just for one party, that's less likely that bill is going to move forward. But by having that grassroots network of support, which engages with both Republicans and Democrats, we're able to increase the likelihood for a bill, a standalone bill, or a funding bill to be passed. And our advocacy creates lasting relationships that'll lead to different opportunities later on, whether they're joining the Vision Caucus, which we'll talk about, or supporting other pieces of legislation that are critically important. So advocacy always is never just one day out of the year. It truly is something that is 365 days through the year. Now I just want to share some examples of how advocacy is currently shaping vision, health policy, and funding. So if you've been clued into our advocacy efforts over the past few years, I'm sure you've heard about the EDV Act before, which is the Early Detection of Vision Impairments for Children Act. And that is currently being led by Congressman Mark Vesey, a Democrat from Texas, and Congressman Gus Bilirakis, a Republican from Florida. And again, those two are champions of ours because of specific linked personal contacts and connections that we've engaged with them over the past few years to get their support on this critical piece of legislation. It is a bipartisan piece of legislation. We have Republican supporters, we have Democrat supporters, and I actually have to update the slide because we have added a few more co-sponsors. So I believe we're about 7 or 8 co-sponsors now currently on the bill. And the reason why we have co-sponsors are because of local advocates who have engaged with their congressional members, educating them about the priorities for our community, sharing their personal experience, and relating how EDV is critically important and how that will truly make a difference in the lives of children, and making sure that we have that early detection component as well. So where we are now, congressional offices, the government is back open, so they are back to engaging on the policy process and focusing on pieces of legislation. They are more aware of the importance of addressing vision health gaps locally and nationally because of this continued effort. So we know that in addition to gaining support for the Vision Caucus and for the piece of legislation, we're continuing to raise that general awareness among members of Congress about how important it is. And you heard from Dr. Hicks and Dr. Allison how these different areas are affected, but also what we do here in Washington is tie that in. So going into the folks from Michigan and explaining to them how important supporting our priorities are, or addressing some of these issues with the New York delegation, specifically Western New York or others across the state, and really tying in how important it is for their support to be on our priorities to ensure that we're making a difference in the vision space. Now, why federal funding matters. The past few months, a lot of folks have been focused on federal funding because the government was closed, the longest government shutdown in history for 43 days, where no funding was being disseminated. And that's because there is a great importance on how much the federal government spends. And it's critically important in our space that the federal government continues to support vital public health surveillance, community level interventions, and research, that they continue to strengthen the coordinated and national approach in addressing public health issues, specifically at the Centers for Disease Control and Prevention. The CDC has a vision and eye health program that is critically important, that it remains supported. We're fortunate that there is specific dollars that get appropriated, for that CDC program. But it's critically important that year after year, Congress continues to strengthen and grow that program to ensure that we have the continued resources at our disposal to address vision and eye health. That's on the public health side. On the research side, it's critically important at the National Institutes of Health for there to be continued funding opportunities and increased funds for institutes like the National Eye Institute. That is the major institute at NIH that focuses on research. So it's critically important that the more funding that NIH gets, the more funding that NEI gets, the more research that they're able to provide to help us get a better understanding of vision and eye health issues, how it relates to other conditions. We heard a lot about social determinants of health. What opportunities are there for cross-institute research opportunities? We heard about issues in certain populations with diabetes prevalency. How do we address all of these issues? The way we're able to do that is by having that robust federal funding. And the more funding generally that's available across the board, the more likely we're able to see greater health outcomes. So folks may hear all this and say, well, what can I do? How can I make a difference? The most important thing you can do is use your voice, sharing your experience, whether you're a patient, a caregiver, a loved one. What has your journey been in the vision and eye health space? Have you suffered from vision loss? Are you a caregiver of somebody who has suffered from vision loss? All of that is critically important. I work with my colleague, Sarah Brown, at Prevent Blindness, advocating for our priorities on Capitol Hill. Both of us have great relationships with members of both the House and the Senate. We go in, we speak with them, we ask them to support the EDV Act, we ask them to support more funding. The one question we always get is, how does this affect my constituency? How does this affect my congressional district? How does this affect my state? So it's critically important that everybody in our patient community uses their voice in advocacy. And I know that folks can hear advocacy and think, wow, that's not really sure how to do that. Fortunately, we have made it very accessible for folks to engage within advocacy. I encourage you to reach out to Prevent Blindness to get more active in the advocacy space, because there really is a lot of important work that is happening here in Washington that really gets affected by you using your voice. So I thank you in advance for the advocacy that you will be doing, and happy to answer questions that folks might have. And I think I'm turning it back to Jeff.
Yes, thank you, Phil, and always do such a great job of showing me up by wearing a necktie. But I guess that's what comes with working in DC, right? I appreciated your remark about how, and I've been on some of these meetings, how they're always asking, well, what does it mean for my constituents? And I always find that an interesting answer or question, because as we know, pretty much every human being is going to have an eye health issue at one point or another. And so it really impacts everybody. But I really appreciated all of these presentations. One question, and I might direct this to you, Dr. Allison. We've talked a little bit about how social determinants of health can impact policy and impact public health. I'm curious from your perspective about why would it be important? Why is it important for the general eye health practitioner, optometrist, or ophthalmologist to understand social determinants of health and how they're impacting their patients?
Yeah, great question. So I'm just going to give you an example. If you gave a patient a prescription for glasses or a prescription for medication or diabetic medication, and they cannot afford to get it, they don't have a job, it makes no sense. So that's a part of social determinants of health. So it's a financial, if you give people a way to make an income, giving them job opportunities, giving them education opportunities, then that will make them more. A good example is when Patrice talked about affluence. You don't even have to be that affluent. You could just be middle ground. Just have access to care, have access to education, have access to healthy foods, have access to so a lot of times we see patients, we give them medication, but we don't look at the other part. That's just only 20% of us, the treatment. So we have to look at the whole picture. Find out, who do you live with? How do you have people that are visually disabled or not able to walk. We give them a prescription. How are they going to get their medication? How is your community? How is your how do you go to the supermarket? Do you have a supermarket in the area? Is it safe to go to the supermarket? Do you have transportation to come to work? Do you have your copay? So these are all issues that affects a person's healthcare. So the fact that they may come to a doctor, and a lot of times they show up when it's advanced because of the other issues. They have no
Hmm.
one to take them to the doctor. So, and especially in Western New York, where you have to have a car in order to get around. So that's a great question, and it's just more than just a vision problem. We have to look at the entire person.
Yeah, and that's true really across the whole healthcare
Healthcare,
ecosystem.
correct.
Um, Dr. Hicks, what are Phil talked a little bit about some of the challenges with federal funding, et cetera, right now, but what are some of the implications of the disappearance of federal data and funding to support it for vision research?
Yeah, thank you so much for the question. This is very timely question. The issues with the disappearance of the data is, so I mentioned my data that I used within the analyses came from 2018 to 2022. So that's a 5-year span. Um, I've done similar analyses where I'm able to track this over time. If data stops, we're not going to be able to monitor how these outcomes are changing over time, whether that's visual difficulty and blindness or other eye health outcomes. Additionally, say there's an intervention that's put into place, we can't monitor over time to see how that may be changing. Um, and so there's big implications for that. And then if we don't have this data, that also makes it more difficult for the researchers. Like if we have to pivot, we may have to pivot to a data resource that's um, maybe doesn't match the needs of our research study as well. One example I will give is like EJ Screen was a data source that was available that's recently. I don't know if it's back up, but it was offline. And so trying to identify the data sources that were available through EJ Screen, I had to kind of pivot some of my work to try to find other data resources. So really, I think it goes back to, monitoring over time. If it's not available for certain regions, it's really nice to have this national level data. And so we may have to pivot to more what is available within our states. So it can definitely bring some challenges for research and then for public health implications monitoring over time.
Yeah, yeah. And certainly data is it, and data research, it's so important to have consistency in measurements across time so that we can track, what's going on. So it certainly is challenging right now. Dr. Allison, um, what are some of the challenges with screening in diverse populations?
Yeah. Um, Great question also. So screening is always a good thing because it can pick up early diseases. And I think we should train primary care doctors. Anyone can get trained to screen, can get telehealth where you can get pictures and then send it to a reading center and therefore diagnose patients early. One of the big issues with screening is that a lot of times patients don't trust it because they think that you're just coming in to collect data and there's no follow-up. So so sometimes it's hard to get the patients to come on board. So you have to build a relationship. You have to start meeting with stakeholders. You have to um, see where you can align with them. And once you start creating that relationship and they realize that you're not going anywhere, that you're really there to help them, and maybe in addition to screening, create a stable um, place, maybe working in a clinic in the area so that you're not just coming in with a van and seeing patients and then leaving and bringing workers that are not as, I don't want to say qualified, but not as trained as, say, if you went to a university setting. So I think if that not only do they want access, but they want quality care, they want comparable care. So I think those are some of the challenges with screening. Glaucoma screening is also very difficult because it's not only checking the vision and the pressure, but it's more encompassing. So I think we have to find a way to get it number one covered. And number two, get it into some of the primary care clinics where they already know the physicians and they're trusting of them. And then work with them, ophthalmologists, optometrists, working with them to create a training model, something like what you guys have, to train vision personnel so that it can help with the screening, send it to a reading center, and maybe that will help. But it's definitely something that we have to do because we're not getting any more. We're getting a shortage of physicians and of optometrists and ophthalmologists, so we have to find a way to screen, but screen more with more quality
Yeah.
and with more specificity so that patients can realize that we really want to help them.
And I think to your point, you kind of alluded to this also with more consistency. They need to see,
Consistency,
patients need
correct.
to see that we're there in their communities all the
Right,
time and not just popping in once a year and moving on.
right.
Um, so as we kind of wrap up here, Dr. Hicks, what can we do to help? What can people in general do to help share the importance of these data resources and why it's the work that you're sharing and other researchers are so important to eye health?
Yeah, so I think there's, dependent on where your role is in this. So researchers, clinicians, public health researchers, vision researchers can utilize these data sources within their own patient populations or in the regions that they're looking at. Because if the data is not utilized, then we don't have information to share with the public. And then I also think that patients can obviously partner with patient advocacy groups, such as Prevent Blindness to, share their story. And I think Prevent Blindness does a great job at, helping share patient stories with policymakers, but also adding in the component of how the data can, combine with the patient stories to really get the message across. And so I think really teaming up and kind of going back to that the need for collaboration, right, across researchers, um, patients, as well as the advocacy groups to really tell the complete story. So I think it really, the data helps to enhance these personalized stories to, end up influencing policymakers.
Yeah, I always think it's so important to bring to policymakers, and I'm sure you would echo this, Phil. Marry up the data with the person. That's really what can help. Well, as we are at time here, so with that, I'd like to thank all of our presenters. Please also go to our website and find our advocacy resources. It's easy to find from the homepage and become involved with our advocacy efforts. Thanks a lot.